Angina. You've heard the term, but what does it mean? Stay tuned and I'll let you know. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warwick Bishop and you're watching the Healthy Heart Network. First, a definition. What does the term angina mean? Well, angina has its roots in either Greek or Latin. To be honest, I can't remember which, but the term itself refers to a feeling of strangulation. This is the symptom that people have when there's not enough blood getting to the muscle of their heart. This shortage of blood flow can occur in two ways, and I really want to help you understand those two ways. The first way is a stable situation that we call stable angina. The second is an unstable situation, obviously called unstable angina. In stable angina, we deal with the gradual build-up of a narrowing in the arteries, something like this, that is limiting flow when the person does something physical. My grandpa had stable angina for years. He'd walk 200 metres up the road, he'd get a bit of strangulation or angina, he'd take a puff under his spray and off he'd go again. When people have angina like this, a stress test is a really good way to reproduce the symptom and see if it really is from the heart. Unstable angina is a different box and dice altogether. Unstable angina arises when a plaque ruptures, and that plaque could be non-flow limiting or flow limiting prior to it rupturing. When the plaque ruptures, components of the bloodstream clump together and can block or nearly block that artery. If it completely blocks the artery, that's a heart attack or a myocardial infarction. If it almost blocks the artery, it gives rise to unstable angina, and that has to be taken seriously. I want to tell you about a very close friend of my younger brother. His name's Tim. He called me up a number of years ago, but this phone call was different. It was 2 o'clock in the morning. He woke me from sleep. I was a bit confused, truth be told. I wasn't on call, I wasn't expecting a phone call. And there's Tim on the other end of the phone. When I eventually woke enough, I said, "What's going on?" He said, "Mate, I've got pain in the chest. What do you think I should do?" Well, he was actually hundreds of kilometres away. I couldn't assess him. I couldn't do anything sensible for him. I knew it was 2 o'clock in the morning. My wife had been woken. I wanted to go back to sleep. But this guy was calling me because something was wrong. I actually said to him, "Do you get indigestion pain?" He said, "No." I said, "Well, what does the pain feel like?" He said, "Bad, and it's in the centre of my chest." I said, "It sounds like your heart." I said, "Tim, I could tell you all sorts of things to do, but the thing you really have to do is go to hospital and find out what's really going on." I left it at that. I woke up the next morning and his wife texted me at 7:30 in the morning to let me know that within 20 minutes of arriving at the hospital, Tim had had 2 cardiac arrests and had been resuscitated on both occasions. He nearly died that night. He had 2 children under 5. If he'd not taken that seriously, what would be the other alternative? So this is a serious condition. If you do go to accident emergency with chest pain, what they're going to do is a number of things. They're going to do an ECG, the dots on the chest. You've seen them on TV. They'll do a blood test called a troponin. This is an incredibly useful marker for whether there's any damage to the heart. My approach for dealing with chest pain in accident emergencies, I've laid out in a flowchart, which I'd like to run through for you, just so you understand where cardiac CT imaging may be beneficial in the workup of chest pain for you or someone you love. So presenting with chest pain that's gradual, this is straightforward. My grandfather, A stress test is a very reasonable first test to try and reproduce the symptom and see if there's objective evidence that the heart's involved. Remember though that a stress test will only show us if the arteries are narrowed, and so that's pretty late in the event. It's late in the process. Gradual chest pain can also be evaluated by cardiac CT imaging, which is a really neat way to see what the health of the arteries is over and above any focal narrowing. If we're dealing with people who have an acute episode of chest pain, like unstable angina, these people have to go to accident and emergency, as I've just explained. If that blood test is negative and there's no changes on the ECG, then there's opportunity for further investigation. If that blood test is positive and confirms problems with the heart, or the ECG is abnormal, then this person needs to go straight into hospital and be admitted for invasive testing, invasive coronary angiography, to establish exactly what's going on. In the less acute situation, then there's the option of stress testing or CT imaging. Remember, stress testing isn't a perfect test. It will miss about 10 or 15% of narrowings. And also it doesn't show us the health of the arteries underneath. The other option with the less acute chest pain, the negative troponin, negative ECG, is that person may go to CT angiography. This will show if there's a stenosis, but really importantly, it'll show us the health of the arteries and whether there's other areas that may actually be a problem over the next 5 to 10 years. And this is incredibly valuable information. So my practice is to tend toward using cardiac CT and CT angiography to try and give us more information about the health of the arteries. Let me show you why. This is an example of a patient who did come through this process. In fact, they ended up having an invasive angiogram, and you can see that this artery here shows no evidence of any narrowing whatsoever. But the same patient also had a CT scan, and you can see without any doubt at all that there's a nasty plaque here, a small focus of calcification and some dark cholesterol plaque. This is really a concern, not shown up whatsoever by filling up the lumen, but only demonstrated by looking at the lumen and the wall. This fills the whole of the donut. This looks at the whole of the donut and the donut. Chest pain, it's incredibly important, and unstable angina is a potential red flag. Please don't underestimate it. Chest pain or angina is literally the muscle of the heart not getting enough blood, and it gets a cramp, a bit like you would get a cramp in the leg if you overused it, or a bit like you get a cramp in the leg if someone closed down the blood supply to it. It's pain of cramp. This can occur in a stable manner, as I described in my grandfather, or an unstable manner, and that unstable situation is such a concern, you must treat it seriously. It's a medical emergency requiring immediate evaluation, because your life could depend on it. ECGs and blood tests help us in the acute accident and emergency assessment and can guide further testing. If there's a high-risk situation, you've got to go to the cath lab, there's no question. But there are other options if the ECG and blood tests don't show an acute problem with the heart. My own habit, my own practice is to always treat as if plaque is present until proven otherwise. So if I see someone with chest pain, I often will commence therapy as if they have coronary artery disease, even before I've had the chance to investigate them, trying to make them safe before we even know fully the extent of their problem. I consider it a bit like an airbag or a safety belt until we know more. Remember, cardiac CT imaging or CT angiography with injection in the arm is 100 times safer than an invasive angiogram. And importantly, it'll show us plaque features that just might not be visible at all on invasive angiography. And I think that's important. Look at this. I'm going to end up there, but I'd like you to stay tuned for how a painful rib led to a change in management for Pamela. this episode, you will have started to understand chest pain and where that fits in and how we manage it. The case for this episode, however, or the cases I've picked for this episode, are going to be about incidental findings leading to finding out what's going on in the heart. I'm going to start with Pam, who is a fit and well woman. Her husband happened to be a patient of mine who we'd already put treatment strategies in place for his cardiovascular disease prevention. Pam had a flu-like illness and had developed a cough over a number of weeks and started to develop pain in the side, possibly a rib pain or a strain, probably from the coughing. The discomfort lasted a few weeks and it just wasn't settling. She was due to go overseas fairly soon on a walking holiday. She had followed up with a local doctor with this discomfort, and the local doctor had organised a CT scan just to see if there was anything going on. And this is what it showed. This was a CT scan of chest, but of course the heart sits in the middle of the chest, so you can't help picking up images of the heart when looking at other structures using a CT scan. You may not be able to pick it up clearly, but there's a bright spot just here. This is the left anterior descending artery, or the artery that runs down the front of the heart. This is a non-contrast study, so there's no outline of the blood vessel. But this is clearly calcification, and with that finding, the patient was sent to me for an opinion. So I suggested that we get a CT coronary angiogram to know exactly what was going on with those arteries, to be most precise. Because with something going on with your coronary arteries, you don't want to be second guessing. So this is the image that we acquired. You can see very clearly, normal, healthy artery. It narrows down, a small focus of calcium, and either side, a dark area, which is cholesterol plaque. This was completely unknown to be present in this lady's coronary circulation. It was only by chance that we came across it. But this is a high-risk lesion, very close to the beginning of a major artery. It was causing narrowing. It had significant non-calcific component or cholesterol component in the plaque. And no question that this lady's risk left unattended would be unacceptably high. We were able to talk this through, discuss exactly what it meant. We were able to commence her on appropriate therapy. She was actually able to get away on a holiday without any problems at all, and we've been following up on a regular basis just to make sure everything has remained stable, and it has. Well, these incidental findings can go the other way as well, and I'd like to share with you the case of Bill, who is a 65-year-old retired carpenter. He did have a past history of smoking, but it was a number of years ago, and since giving up smokes over 10 to 15 years earlier, he'd been looking after himself and was otherwise well. His risk profile was unremarkable, and he came really because he wanted to be more precise about his risk, so we did talk about imaging and thought that on balance it might not be a bad thing to look at his arteries and see if we could be clearer about his risk of coronary disease. This is what Bill's CT scan looked like. An incidental finding of a thick, lumpy area out over here, which was not meant to be here. This was a primary lung cancer found incidentally when we were scanning the heart. We jumped on this as quick as possible. He saw a respiratory physician, a lung surgeon, he had the operation, he had the follow-up appropriate therapies. Everything rolled on very quickly, as you would imagine. I saw him 2 years later. He had had this tumour fully excised. He was fit and well, and his oncologist had told him he was cured. As an aside, although you can't see it in this image, he did have significant plaque in his arteries, and we had been able to put in place appropriate therapy for that as well. Overall, a really good outcome for Bill, and also a really good outcome for Pam. Stay tuned for some patient questions. It's coming right up. Welcome back. This question and answer segment I've decided to dedicate to how I consent patients for cardiac CT imaging or invasive coronary angiography. So first of all, let's look at patients who have no symptoms and are coming to me for a risk assessment. My own practice is to start with a coronary calcium score. This is a very simple test without any contrast at all. If we see nothing in the arteries, this has such a low risk of subsequent event that I often stop there. If there is calcification, then I tend to proceed onto a CT coronary angiogram. This is not level 1 evidence in any guidelines, and I do explain this to patients. There can be an out-of-pocket expense. This is variable in different places. Generally, the cost for a coronary artery calcium might be in the order of several $100s, and for a CT coronary angiogram, a little bit more. So together maybe $500, $600, maybe up to $800, variable depending on where it's done. There is radiation associated with this sort of imaging, and I make it very clear to my patients that that is the case. A simple coronary artery calcium carries with it a radiation dose of approximately 1 millisievert. To put that into context of what we're used to, we know that a mammogram can be performed with about the same radiation dose. So certainly we're not talking about something outside the realm of what we're used to accepting for risk testing. The radiation of a CT coronary angiogram, so following on and doing a second stage procedure, is about the same, maybe a little bit more. I do explain to patients that there is a small risk of reaction, allergic reaction to the contrast we use. That risk is about 1 in 200,000, but again, this has to be put into context. Coronary artery disease kills 50% of the population. The other thing that I tell people is, just as an aside, peanut butter will kill people 1 in 70,000, and that makes it 3 times more dangerous than X-ray contrast. Of course, X-ray contrast has other problems, certainly if you have renal disease, so we're very cautious about giving contrast to patients whose renal function is down. I give my patients heart rate and rhythm control drugs, and the tablets I tend to use are beta blockers. I get them to take good doses of these tablets the night before and on the morning of the day of the procedure. I give them advice about their blood pressure potentially dropping from those medications, and I advise them not to drive with an unfamiliar medication on board. I invite them to fast for 2 hours before the test, and I ask them to get plenty of fluid on board before they start their fasting. That's so that if they do get given the contrast, plenty of fluid flushes through. I also make a point that after they've had their scan, they must make sure they have a follow-up appointment. I have had 1 or 2 patients over the course of the last 8 or 9 years who've just been lost to follow-up. I also emphasise to patients that I want them to make sure they have an appointment so that we can get the results back to them. There seems little reason going through this sort of test so we can make plans for the future if we're not able to relay that information back to the patient and put some sort of strategy in place. So when I consent a patient for invasive coronary angiography, it's generally in the setting of someone who has symptoms, chest pain, or they've presented and they've had an abnormal blood test suggesting strain on their heart, or an abnormal ECG which suggests some sort of abnormality and strain on the heart. These also could be patients who we've demonstrated the likelihood of abnormality through stress testing. These are all clinical features which really suggest that we have to know what's going on with the patient in more detail. And so what I'll say to the person is that an invasive coronary angiogram has risks, but based on your current situation, the importance of us knowing what's going on really outweighs those risks. The risks are fairly set and are reported as about 1 in 1,000, and that's in many centres around the world. I'll tell you more about exactly what that 1 in 1,000 risk is in just a second. We tend to invite our patients who are coming for invasive angiography to see the practice nurse so that they can run through some of their questions. The patient will be fasted. If there's any medications that need adjustment, that'll be sorted. And then we take them for the procedure, which is in a specialised laboratory, as I've already explained. We pass a needle into their wrist or into the artery in their leg and gain access to the arterial tree through a sheath. We pass a catheter up, a small tube, so we can squirt directly into the arteries, and interestingly, they don't feel anything because there's no nerve endings within the arteries. I suggest to these people that it's really important they understand that the test complications are outweighed by the importance of what we need to know. And so then I explain that the problems arise from our tube inside the body. The tube that goes to the heart can cause a heart attack. It can knock off debris that goes to the brain and cause a stroke. It can damage any vascular bed on the way back either to the leg or to the arm. Depending on the findings dictates the next step for that individual patient. Perhaps we're going to use medicines to treat them. Perhaps a stent is appropriate, or perhaps coronary artery bypass grafting. But we have to get that information so that we know what to do for that individual, and that benefit of knowledge has to outweigh the risk of the test. Otherwise, it's not okay. Well, that concludes this episode. Thank you for joining me. I hope you feel a little bit more informed around invasive and CT angiography, and I hope you're looking forward to the next episode. Until then, please don't die from a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover, a paperback, and an audio from Amazon, or wherever good books are sold.